75 health ministers from all over the world signed the Moscow Declaration this week, a commitment to take urgent action to end tuberculosis or TB by 2030. It's thousands of years after the first human cases of TB were recorded and more than a century after the bacterium that causes TB was discovered.
This week we come to you from Moscow, the venue of a very important conference on ending TB in the world. TB may be an ancient disease, but it continues to kill millions of people across the globe. It recently dislodged HIV/AIDS as the world's top infectious killer.
The first WHO Global Ministerial Conference on TB opened with an address by Russian President Vladimir Putin, who lent weight to the fight against the global threat. He described TB as a state priority for the Russian Federation.
We are implementing a number of programs to combat this disease and providing stable budget financing for these programs. We pay much attention to improving the diagnostics and treatment and creating modern vaccines and tests based on biotechnology.
The President's presence sent a clear message. It was time for coordinated and consistent action by countries against TB. Public health experts are calling for transformation of the field of TB research by giving it attention and resources. TB remains a poorly understood disease fought with antiquated tools. Currently, the only vaccine is BCG, developed over 100 years ago. It offers protection for children but is not effective against adult pulmonary TB. A safe and effective vaccine against TB will be critical. Diagnostics can be non-standardized and imprecise. Drug therapies take years and are toxic. The development of new drugs lags behind the emergence of drug-resistant strains. TB kills more than 5,000 children, women and men each day in the world. It leaves no country untouched, a fact underscored by the huge turnout of health ministers. Countries with high TB and multi-drug resistant TB include India, Brazil, China, South Africa, Indonesia, Pakistan and Belarus. The overwhelming majority of cases and deaths are among poor and vulnerable people living in low and middle income countries. India will be playing an important role in the fight against TB.
The spotlight on TB is intensifying. India has the highest burden of TB in the world, accounting for 25% of the global cases.
India also has the highest burden of multi-drug resistant TB and the second highest of HIV-associated TB. While the world has committed to end TB by 2030, India has set itself an ambitious target by declaring it will end TB by 2025. Health Minister J.P. Nadda shared India's new National Strategic Plan for TB elimination.
We have started a program which is called as JAM. J stands for Jan Dhan Yojana. All these plans have been supported financially also. Practically $3 billion are being spent for this prevention, and this is being done by domestic funds, and we have seen to it that free detection, free prevention and free medication is to be done.
The plan is set to allocate over 12,000 crore rupees over the next 3 years for greater private sector engagement, nutritional support and investments in TB research and development.
Under the leadership of Prime Minister Modi ji, we are trying to see to it that every micro planning is implemented at the grassroots level. And we have taken 2 campaigns in 250 districts. And it is approximately 30 million people have been screened and 15,000 active tuberculosis patients have come.
Among the participants were 7 politicians from India who are part of the global coalition against TB set up 4 years ago. They expressed hope over the new government strategy, but also concern at the enormous challenges.
Instead of waiting for the patients to come to the hospital or to the PSC, we should go to the people, and especially those who are living in the slum areas, those who are in the rural areas. And I have raised this question in Parliament also, like in my constituency. If we go to those Dalit areas, even we feel ashamed that why we are asking votes for them.
By almost 1/3 of the Meghalaya is full of forests, so the mosquitoes are there. So along with the malaria, also the TB comes. And then Meghalaya being in the areas very near to Bangladesh, so we have got lots of drugs also in Meghalaya. So drugs, and then it goes along with AIDS. So there's an increase in AIDS patients and all. So TB, whenever there's AIDS patients, that that is more dangerous. So I think Meghalaya also has to do a lot.
That is an ambitious plan. When you have an ambitious plan, you have the will to work, commitment to work. It is very important to reach to the people, reach to the unreached. That is one slogan. It should not be slogan, it should be materialized. So far, if we consider the present situation, it is not very satisfactory, but it is in the right path. The biggest difficulty in this is the awareness, and biggest difficulty is again the poverty and underdevelopment.
MP Hina Gavit said her constituency Nandurbar in Maharashtra needed CBNAT machines, a modern diagnostic tool that can detect active TB bacteria in sputum samples and the presence of drug resistance in 2 hours instead of the 1 month required for standard sputum tests.
Nandurbar is a tribal area, and we have maximum patients suffering from tuberculosis. One reason of tuberculosis being that there is malnutrition, undernutrition, and not many people are aware about tuberculosis. And a very good initiative that Government of India has taken is they have opened these NAC testing centers. These are the diagnostic machines which every district in the country is going to be given. Medicines should be made easily available. Diagnostics should be done at a faster rate.
I'd recommend it to the minister that every block in India needs a machine. There are about 600 districts. The one machine per district is not enough. There are numerous hospitals. We must take it to primary centers of India. We must take machines to sub-centers. That's where the disease is. We must take it to the people. Okay, because nobody is going to come to the district for even diagnosis. That's exactly the fundamental, the problem of the whole issue. Look at Mumbai. Mumbai has the highest rate of incidence of drug-resistant TB. Because obviously if one person is infected, these ghettos, 100 people get infected in a span of a week. And how do you handle these problems? By planned urbanization. So these issues also have, these issues are cutting across various ministries, not just health minister.
TB advocates struck a note of caution, saying the government needs to hear voices from the ground.
We run a support group for MDR and XDR patients. All our members are in the age group of 25 to 35. We have doctors, we have engineers, we have chartered accountants. I mean, these are young professionals, and TB is wiping that out. My problem with my country is that the minute you start thinking of a plan, we think we have ended TB. The big gap of implementation is where the real problem is, and you need to have process indicators. We started Nikshay, fantastic, but notification does not mean ending. Notification does not mean elimination. We have daily regimen right now, fantastic, but starting daily regimen is only one step towards elimination. It's not NTB. We have gene expert machines, but are we hearing from patients who go there for testing that there's a stock out of cartridges? If we don't hear that, how will we replenish? How will we address it?
From Moscow to India, The key to controlling TB in India is likely to be the government's engagement with the private sector. Over 50% of the estimated TB patients seek medical care from private practitioners. These patients need quality TB management services.
Through sessions like this one in Nagpur, the centre is reaching out to private practitioners. The aim is to build partnerships with them and to support patients who receive their care. The worry is that nearly 10 lakh TB cases every year go undetected by health systems.
किसी ने बोला ये हो गया, किसी ने रियल चीज़ क्या है, डायग्नोसिस क्या है, वो कोई बता ही नहीं पाता था और कोई कर ही नहीं पाता।
टाइफाइड का मेडिटेशन दिया था उसने, तो 15-20 दिन ली थी मैंने 20 दिन ली थी ट्रीटमेंट। उसके बाद भी चक्कर वगैरह आते थे, तो फिर आराम नहीं लगा, तो फिर इधर डॉक्टर चेंज कर दिया।
This usually happens in practice. Patients move around to a couple of doctors and then they come to the government setup, and there they are like channelized with the symptoms. Like she had cough, we got a sputum test done, the bacteria was isolated and she was immediately directed to start anti-TB treatment.
Underdiagnosis and inappropriate treatment leads to drug resistance.
These missing cases are the most vulnerable in the community because they are transmitting the disease within the community and they are a most vulnerable population.
2 years ago, the centre launched the Universal Access to TB Care project in collaboration with WHO and Bill and Melinda Gates Foundation in Nagpur.
It is a great challenge to involve all these private practitioners in the program and to detect all the TB patients, so that we should come to know what is the load of TB in Nagpur city. In that program, those patients who were going to private sector, they are given now medicine of tuberculosis of the choice of private practitioner, free of cost. All the patients, those who are going in the public sector and those who are going in the private sector, all are getting free of cost medicine.
The project has improved treatment completion by patients. Earlier, some would stop treatment midway because they could not afford to pay for medicines and diagnostics.